All right, good evening, everyone. I'm Laurie Ledley, the founder and president of Valley Sleep Center. And I'm here tonight with Jill Fricke and Laura Link from Respicardia. And we are talking about sleep apnea and heart disease. And so for those of you who are unaware, it is the leading cause of sudden death in America. And we have a great new innovative treatment for anybody who's suffering from central sleep apnea. So it's really exciting to see all these new technologies coming to face. So I wanted to say thank you so much, Laura, for arranging this. Thank you, Jill, for giving us your time. She's on the East Coast, guys. It's 5:30 here, but it's 8:30 where she is. She's ready to go to sleep. But I just want to welcome you. Thank you so much. And if you want, you can go ahead and share your screen. If anybody's on the webinar and you guys have questions, feel free to use the Q&A or the chat, and then we'll go over those at the end. And then someone is going to win a free watch pat, which is a home sleep test, really cool technology, disposable. And Laura will announce the winner. I'll be in the background, and she will announce the winner at the end of the webinar. But feel free to chat your questions. And let's just give it like another 60 seconds. Oh, it's 5:31. We could start. Yeah, go ahead. This looks great. See.
Good evening, everyone. My name is Jill Fricke, and I'm a principal field clinical engineer with Respicardia, and I started with the company in 2013. And I'm thankful for the opportunity to speak to all of you this evening regarding sleep apnea and its relationship with heart disease. So I am going to advance my slides here.
Jill, go ahead and change it to a presenter view.
What it looks like. There we go. How is the view there? Better or no?
Yeah, go up to display settings and presenter view.
Laura, is it better there?
That looks good.
Is that better?
Yeah.
Looks great.
Perfect. Thanks, ladies. So there are two types of sleep apnea, and we're going to review both of those apneas this evening. We have what we consider obstructive sleep apnea and central sleep apnea. So the types of apnea are represented here in this slide. And what we're looking at is central sleep apnea occurs when the brain's area that controls your breathing does not function correctly during sleep. So it's truly functioning with the brain having a disconnect to communicate to the phrenic nerve to send a message to the diaphragm to take a breath. This is a very different indication than obstructive sleep apnea. Obstructive sleep apnea is caused by an obstruction within the upper airway that restricts oxygen to the body. So central is lack or no effort to breathe, and obstructive sleep apnea is an obstruction in the airway, but there is still effort to breathe. Some patients actually have a combination of both central sleep apnea and obstructive sleep apnea. Both OSA and CSA may also result in serious health consequences, including increased risk to heart problems. With obstructive sleep apnea, as you can see in the diagram to the far left, this is normal breathing. So you can see that the air is going through the nose and the mouth. It transmits that air through the soft palate, underneath the tongue, and into the epiglottis. When we have obstructive sleep apnea, the airway actually collapses around the soft palate area and the tongue, restricting airflow at the epiglottis. So you can see the difference between an open airway with the normalized breathing and the photograph to your far left, and then the obstructive version to your far right. When we look at central sleep apnea, again, this is the brain not sending correct signals to move the diaphragm for normalized breathing. So as you look at the two yellow dots on the side of the lungs, you can see that these are the phrenic nerves that radiate the signal to the diaphragm for the diaphragm to contract to take a breath. So very different mechanism of action with central sleep apnea in comparison to the obstructive sleep apnea that's noted in the airway or the upper respiratory area here. Some of the signs and symptoms of sleep apnea in general, as you look at this round figure, if we start at the very top at what I would consider 1 o'clock on a clock, it's an orangish based color. And these are daytime symptoms that patients may experience that have sleep apnea. This can be early morning headaches. It can be daytime sleepiness, poor concentration throughout the day, some levels of irritability, and then falling asleep during our routine activities during the afternoon. And due to the high incidence of sleep apnea in heart failure and atrial fibrillation patients, this is something that's very interesting to look at. As we go to the nighttime symptoms, as we start, let's say 11 p.m. on a clock up here at the top left in blue, we may hear loud, persistent snoring, witness pauses or sensation in breathing or respiration, potentially by your spouse or bed partner, choking or gasping for air in the middle of the night while sleeping, restless legs or fragmented sleep, and frequent and constant visits to the bathroom throughout the night. So these can be symptoms or signs that you may be suffering from sleep apnea. So who is at risk for sleep apnea? So the risk factors that we look at for sleep apnea patients are those that could include high blood pressure, atrial fibrillation, other abnormal heart rhythms, heart failure, obesity, the male gender, and those individuals greater than the age of 50. The larger risk factors that we seem to notice are the ones highlighted in the box, and those are the top 4 previously referenced: the high blood pressure, the atrial fib, the other abnormal heart rhythms that could be ventricular related arrhythmias, and then heart failure diagnoses. Associated with risks of untreated sleep apnea could be levels of depression, diabetes, heart failure, elevated or high blood pressure, and concentration and memory problems. So it's all a result of good sleep and good sleep hygiene and appropriate evaluation and treatment if you do have sleep apnea. So how common is sleep apnea in patients that are diagnosed with cardiovascular disease? When we look at the clinical trial data from ITAMAR, we can see that their data shows that patients with undiagnosed sleep apnea is a major comorbidity of cardiovascular disease and a significant risk factor for stroke, coronary artery disease, congestive heart failure, and atrial fibrillation. So when we look closely at the breakdown, you can see that drug-resistant hypertension is at the higher percentile at 83% in this data. Congestive heart failure is sitting at 76, with type 2 diabetes at 72, stroke at 63, those implanted with a pacemaker at 59, those with arrhythmias such as ventricular tachycardia or ventricular fibrillation at 58%, coronary heart disease at 57%, and again, atrial fibrillation at 49%. So you can see that the evaluation or the comorbidities that are referenced here seem to have a higher link to patients that could be diagnosed with sleep apnea. So let's look at high blood pressure and sleep apnea. Sleep apnea is a risk factor for high blood pressure or hypertension, and hypertension is a risk factor for sleep apnea, so they go hand in hand. We say that about 60 to 80% of our people with obstructive sleep apnea have high blood pressure, and about 40% of those individuals with high blood pressure also have sleep apnea. What's interesting is 90% of the people with resistant hypertension also have sleep apnea, and those are patients that require at least 3 medications to control their blood pressure. So evaluating blood pressure is a very important risk factor as we look for the potential in diagnosing sleep apnea. If we go back to the previous slide, we can see that drug-resistant hypertension in this study was approximately 83%, which correlates with the high blood pressure and sleep apnea that's referenced on this slide. So atrial fibrillation and sleep apnea. It's estimated that 50 to 80% of people with atrial fibrillation have sleep apnea, but most of those will have obstructive sleep apnea, with only 20% of them having central. Again, obstructive sleep apnea is the collapse in the airway, and central sleep apnea is the brain's inability to communicate to the diaphragm to breathe at night. With having untreated sleep apnea increases your risk for developing atrial fibrillation. And then also treating the apnea has been shown in data and many studies to improve all types of treatment outcomes for atrial fibrillation. As we look into one of the studies that was completed by a pulmonology group, we're looking at the comparison of atrial fibrillation using CPAP in those who stopped their CPAP 1 year after starting. So in this trial, you can see in the lighter kind of purple pink shades, 25 or 23.53% of the patient population within this trial, we had atrial fib or flutter, but a majority of the rhythm when treated with mask-based therapy was normal sinus rhythm at 76.47 for their atrial fibrillation. The patients in group B who stopped their CPAP use after 1 year, in the dark shaded green area, you can see that their atrial fibrillation or atrial flutter burden increased after 1 year, and their sinus rhythm decreased in comparison to group A, where they were treated with mask-based therapy. So in comparison of the two groups, you can see that patients with atrial fibrillation fared much better with managing their atrial arrhythmias on mask-based therapy in comparison to being off mask therapy at 1 year. Other arrhythmias in sleep apnea would include our ventricular arrhythmia classifications. And patients with heart failure and sleep apnea are twice as likely to receive a shock from their implanted defibrillator due to an arrhythmia. And it is much more prevalent in patients with sleep apnea without heart failure. Ventricular arrhythmias in patients with sleep apnea also have a high recurrence rate in their treatment if their sleep apnea is not treated. So the treatment of sleep apnea has been shown that it decreases that ventricular irritability. Sudden cardiac death has been noted to be 2 times more likely in patients with sleep apnea. And then slow heart rhythms such as a heart block or pauses are more common in patients with sleep apnea. So again, we're talking about the ventricular side on the arrhythmia burden, and prior to, we were talking about the atrial burden. As we look a little bit more into the data related to sleep apnea, sleep disorder breathing is common in heart failure, and it's untreated the sleep apnea that can overlap with heart failure symptoms, which sometimes can add some confusion if it's actually sleep apnea or heart failure. So in this data set, we can see in the US population that we approximately have 6.4 million patients in the US diagnosed with heart failure. And when we look at the pie graph below, 1.5 million patients, or 25%, have no sleep disorder breathing. When we look at the breakout between the obstructive and the central apnea that was previously discussed, you can see that OSA is sitting around 2.1 million, or 37% of the population, and then the central sleep the 57% of the population, and then the central sleep apnea component is 2.1 million within the population. So when you look at the patient's symptoms that may be in comparison with heart failure and or sleep apnea, the common things that are heard in clinics are fatigue, frequent hospitalizations, nighttime urination, a frequent awakenings at night, and memory or thinking difficulties. Patients with central sleep apnea may also have observed apneas or sensation in respiration or breathing by their bed partners. And people with apnea have frequently do not snore, which is very different from our obstructive patients where we may hear snoring throughout the night. And I think those of you that may have some obstruction may be aware of that snoring as well. But many people with central sleep apnea frequently are not aware that they even have arousals or awakenings at night where they wake up, they can't sleep, they get up and they go to the restroom, or they get up and walk around the house. They're not sure why they can't fall back asleep, but sometimes those arousals can actually be due to the central sleep apnea, but they're not aware that it's a sleep disorder breathing problem. So readmission rates related to heart failure. So in central sleep apnea, we can increase our risk in heart failure readmission rates. So when we look at the data here from the NIH, we can see that 50% of our heart failure patients with central sleep apnea were readmitted to the hospital at 6 months after discharge. And then over 25% of that patient population with heart failure and CSA had 2 or more hospital readmissions within 6 months, stating the importance of treating your apnea central based for your heart failure readmission reduction. When we look at an additional NIH study, what we're looking here is how our patients that are diagnosed with central sleep apnea or obstructive sleep apnea with a heart failure diagnosis, what is the death rate in comparison to those patients that have no or minimal apnea burden? So when we look at the dark gray or black line at the very top of the screen, we can see that this is the patient population with minimal or no sleep apnea. And then when we look at the blue graph line, we see that the blue graph is representing obstructive sleep apnea and the red line, central sleep apnea. So the patients that have been diagnosed with central sleep apnea or obstructive sleep apnea have a higher rate of death in heart failure than those patients that have minimal to no sleep apnea, reinforcing the importance of diagnosing and treating apnea in our heart failure population. As we continue on about symptoms, these are common questions that are asked to try to understand in the heart failure population or heart disease population. Could you potentially be someone that needs to be screened for sleep apnea, whether that be obstructive or central, or hopefully screening proves to have no apnea burden once the study is completed. But if you are having trouble with concentrating, you've ever been told that you stop breathing while you're sleeping, you snore when asleep, you have been told that you have atrial fibrillation, or diagnosed with heart failure or sleep apnea, we recommend that you work with your sleep clinicians or providers or primary care physician to make sure that you're being evaluated appropriately for sleep disorder breathing. These are common questions that are asked in the cardiology office a lot of times as patients are being evaluated for their normal workup within their cardiac consult. And then just one last slide on data. So 25% of the adults have sleep apnea. So the adult population, if we think about it, 25% of those walking around have central or obstructive or a mixed sleep apnea. 60% of our patients with cardiovascular disease are suffering from a sleep apnea, again, whether that be obstructive, central, or a mixed apnea. And 85% of all sleep apnea patients still remain undiagnosed. So the important piece regarding the statistics is that we do need to make sure that we're getting tested. And if we are tested and we test positive for needing some type of medical management for our apnea, that we're working with our healthcare providers to get the type of treatment needed to assist with that apnea burden. So I would like to end with any questions that anyone might have that Laura, myself, or Lori could potentially address related to apnea.